should a baby double their birth weight? Not 1 year. What should they do by 1 year? 3 times. Yep. Not quite even that much. About 4 months. 4 months you should double your birth weight. How much percentage-wise is acceptable for weight loss of a newborn in those first couple of days? 5 to 10%. Yeah, you don't want any more than 10%. How many saturated wet diapers is the bare minimum you need to say that a baby is hydrated?
4.
4. Perfect. Is mastitis a contraindication to breastfeeding?
No.
It's incredible. I don't know what Dr. Love has you guys doing. What is the recommended dose of vitamin D a day for a baby who is 7 months old? 400 IU. How much about if they are 18 months old? 600 IU. Yep. For your BMI percentiles in a child over 2, what are the normal percentiles? 5 to 85. Correct. If you have elevated direct bilirubin, what imaging do you need to order?
Liver ultrasound?
A liver ultrasound, what are you looking for?
Biliary tree?
The biliary tree. Correct. Okay. Okay, so we are at the point where we had talked about some of the normal growth. Now, this lecture is about development, so about the functioning. So normal functioning for the kids, how should that develop over time? So while their little bodies are becoming transformers, now we're talking about how is their functioning happening. And I said I was going to come to this side, and then I didn't. I'm going to do it. Today's the day. Okay, so developmental milestones. When we talk about a child's development, we subclassify that into different realms. So you're going to have their gross motor skills. So what's an example of a gross motor skill? Walking, standing, crawling. Yeah, so you have your large muscle groups, large gross motor skills. Fine motor skills. What are some examples of fine motor skills?
Stacking blocks.
Stacking blocks, eating, coloring. Yep. Personal social engagement. What does that look like for a kid? Smiling, laughing, interacting, joint attention, some of those type of things. Language skills. Yep. Any kind of verbalizations, mama, dad, words, talking. And then problem solving. What does problem solving look like for a child? Yeah, sure. Puzzles. What if you put something just outside of their reach? How do I get myself to that? Right, so there's all these different realms. So you can have a delay in one of these realms, in 2 of them, in 5 of them, in none of them. So you have to look at each of these realms individually. When you look at this, I know you guys hate charts, and I have given up. I don't know why. I mean, they're all, you basically need to know this chart. The reason I say that is because I have not seen a board exam or a PANTS exam yet that didn't have a developmental question on here. But what I need you guys to focus on are 2 categories particularly, gross motor and language. Those are the 2. Because some of your fine motor or any kind of other outcomes, personal, social, those are a little bit more subtle, harder to pick up. Gross motor are those ones that you can do with surveillance. You walk in a room and say, that's normal, that's not normal. Okay, so if we're starting, we already talked about our newborns for the most part. When we're talking about a 2-month-old, let me back up a tiny little bit. You're basically going from a laying down cockroach to I need to be a standing up human who is able to express. So that's that sequence. So we have to start, and it usually will start from the head and work all the way up. So at the 2-month mark, I need to be able to lift my head and lift my shoulders up. The idea of that developmental growth milestone is I could protect my airway. So if I needed to, if I was somewhere, I could move my head to protect my airway. That language skill is that they're starting to make a little bit of some kind of vocalizations. So cooing is usually about the 3-month mark. We'll give you a little mnemonic here in a minute. But shoulders and head are the big ones to know for 2-month-old. 4-month-old now is, I think, of baby yoga. So they should be able to do kind of the up dog position, where they have control of their head and then they have control of their shoulders. So they're able to push themselves up. They're able to roll at least one direction. But if you sit them up, they still kind of fall over to the side. So sitting is not best. Language skill, they're starting to do more interactive, so laughing is really that skill that you see. And if you get lost and you're like, I don't know where to anchor, I have to guess, I don't even know, 6 months sits. So that's where the arrow is there. Anchor at 6 months. So 6 months sits, and 6 months should be starting to babble. So there should be all kinds of different vocalizations. It's nonsensical, but they're laughing, smiling, babbling, making all kinds of things in their own language. So 6 months is your anchor point. If you don't know where you are from there, but you knew 6 months, at least you can give an educated guess. 9 months, the actual skill is that they are mobile. So it doesn't matter how you are mobile. Maybe you are pulling to stand, maybe you're crawling, maybe you're army crawling. I've seen one baby that just rolled themselves across the room, and that was the appropriate skill. They were mobile, so they had problem solved enough and had enough gross motor to get themselves somewhere else. So that will say pull to stand, get somewhere in a kind of scooting position, but really it's mobility. And at that point they're starting to use verbalizations of repetitive consonant sounds. So it doesn't always need to be ma ma ma, da da da. It could be ba ba ba, na na na, whatever it is. It's a repetitive consonant sound that they're doing. 12 months they should be able to stand alone or walking on furniture. They could be walking. And then mama or dada with two specific words. So they should be able to identify a caregiver, and then usually 1 or 2 other words. Yes, no, hi, bye, something like that. 15 months, I really don't like this one, but this is where the boards typically love. They're like walking backwards. I don't think I've ever actually seen a child that's like trying to walk backwards as like a purposeful movement at all, but that is the one. I think 18 months makes more sense of not only are they able to walk, they're able to run very quickly. The words are increasing, so 3 to 6 words. The other anchor point is going to then be 2. So at 2, you should be able to do 2 different levels, meaning you can go up or down stairs. So 2 different levels, and then putting 2-word sentences together. So if you are anchoring things, anchor 6 months and anchor 2. The rest of it you can kind of figure out from there. But there will be a question from this on your test, on something on this one. It's developmental milestones. This is the way I learned it. I think it's a little bit of an easier way to remember it, specifically for language, because it goes with the letters. So 3 months, they are cooing. There's 3 letters in coo. 6 months, they're babbling. There are 6 letters in babble. 9 months, they're starting to imitate. 9 letters in imitate. 12 months, 1 to 2 words. 12 months. 18 months, they have about 18 words. 2 years, 2-word phrases. 3 years, 3-word phrases. 4 years, whole sentences. So if someone says, when should a child be fully able to communicate with a stranger? It should be at the age of 4. Okay, so if you have somebody who comes in for a 5, 6, 7-year-old well visit, you can't understand them at all, that's not normal. And so that's something to talk to the parents about. So I judge that basically at 2, they're about half understandable to a stranger. So if I'm listening to a kid and I can get every couple of words, pretty normal, right? They'll start saying things and parents will be like, they want orange juice. And you're like, really? That's what you got from that? That's incredible, right? Like, it's amazing. And so parents won't realize how much they do or don't understand. So the skill is to a stranger. So just like if an adult came in and you noticed they had high blood pressure, if a child comes in and their speech is not understandable to you, that is on you as the provider to note that that is a physical exam skill that you are seeing that they're not doing and provide care appropriately. So that can be a really hard or awkward conversation to talk to parents about, but a lot of times they know and they're waiting for somebody to bring that up to them. So something to think about. If you have a kid who's not halfway understandable, who's not 3/4 understandable at 3, or who's not understandable at 4, what you don't want to have is a 5, 6, 7, 8-year-old who's in school who can't communicate. So early intervention is going to be better for that language milestone. For your gross motor milestones, I liked this one just a little bit, kind of head to toe, head, shoulders, knees, toes, following all the way down from 0 to 12 months. So if that's an easier way to remember it, head and shoulders, knees, and toes. I'm going to ask you something from this one, so start this one. These are red flags that for development. So if some kids come in and they have one of these things, you should think that's not normal. So from the gross motor perspective, if you have a parent that comes in and says, my 1-month-old is just such an overachiever, they're already rolling, you should actually think that's not normal. There's some hypertonicity and some spasticity, and I'm actually worried that there's a neurologic something underlying or a cerebral palsy that isn't normal. So early and significant rolling prior to that 3-month mark is not just overachieving, something musculoskeletal neurologic standing, not normal. Yes, sir.
Would that be like the consistent ability to roll over, or just like if they did it like once? Or?
No, and one time, kids will do all the weirdest stuff. So if they were like, well, one time you rolled over accidentally, that's a different story than if they're like, hey, they roll over all day, every day.
Okay.
Very different. Poor head control at 5 months. So you're supposed to have head control when? At 2 months, yeah. So if you don't have it at 5 months, not normal. In no way, shape, or form can that be normal. Because if you are that hypotonic, you are not going to be able to sit up at 6 if you already don't have head control. If you're not sitting up by 7 months, that's again truncal hypotonia. That would not be normal. And hand dominance before 18 months. So you should see kids before 18 months using their hands interchangeably to reach for things, to give things back and forth. If you have a kid that will preferentially only use one hand and doesn't use another side, that's also a concerning sign for some sort of hemiplegia or cerebral palsy, for something else going on. So that hand dominance. What I will say with some of those, particularly the gross motor milestones, is I give them till the next well visit to do the skill. So if you come in and they are at 4 months old and they are not rolling yet, I never tell a family, yikes, not rolling yet, right? They're gonna go home, mom's gonna cry, dad's gonna feel terrible. Like that's a bad day, right? So the well visit really is at that 50th percentile. Half those kids should be doing it right then on track. The next well visit is 2 standard deviations away. So if they come in and they're not sitting at 6 months and you're like, yikes, right? Bad day. If they're probably going to do it tomorrow, right? If they come in at that next well visit and they're still not sitting, that's when I start to act on that. Language, they failed their hearing screen. We needed to get them to audiology again by 3 months, so I've already do that one. You're not having any kind of voice pitch, so they're not making any kind of different noises. That would be concerning. They're not doing some sort of babbling and making different sounds by 6 months. You don't have any true words and you're well over a year old. That's a red flag. Proto-declarative pointing, so that is if I said, hey, look up over there, and you're getting joint attention. Most kids will do that much earlier. So if you're not doing that for that shared attention by 18 months, not normal. And then really the bottom one is really that one that I wanted to hit. So that's the one that we use a lot in clinic. If you're not half understandable to 3/4 by 3 or fully understandable by 4, it's really outside the norm. So what do you do about that? So I've noticed I've done this well visit and I'm like, yikes, that's not normal. So again, we're talking mostly about gross motor and language skills. So overall, I'm going to see what was their development like. Do we have a known genetic disorder? Were they in the neonatal ICU for a long time? Were they significantly premature? Is there something else on history that we're looking about to make this up? If it's a speech delay, for the love of God, look at their ears. Do they have ears? Is it malformed? Is something wrong with the ear when you look at it? Something wrong with the canal? If you can can get a hearing evaluation in clinic with a tympanometer, certainly do that. Then your first referral is going to be to audiology, because if I send them to speech therapy and they can't hear, what sort of magic are you thinking that that speech therapist is going to be able to do, right? They cannot do that. So if you send them to speech therapy without a hearing evaluation, the speech therapist will think that you're a ding-dong. So do not do that. Send them to audiology first, then to speech therapy. Most of the time, I will put those referrals in together, but tell parents they need to do the audiology first. If you have a gross motor, so one of those large muscle groups, large gross motor milestones, that is going to go to physical therapy. If you have something in the fine motor movement, so they're having trouble eating, they're having trouble with handwriting, something like that, that's going to be fine motor and occupational. Feeding issues will sometimes go to occupational therapy, sometimes go to speech therapy for specific feeding therapies. And then there's like a million other types. There's like play therapy, sound therapy, vision therapy, horse therapy, swim therapy. There's 1,000 different therapies. So when I ask a history for a patient, I always ask, do you see any other specialists? Do you see any other therapists? I'm trying to get all of these different guys on that history as well. So surveillance, we talked about that versus screening yesterday. So surveillance is going to be, I walk in the room and every single visit I'm saying that's normal, that's not normal, no matter what they're there for. Screening, we're going to do that at those specific times when it would matter. So if we're thinking about, you learned in GI, when do you start colonoscopies? What age? 45. Yep, so you're going to start those at 45. Why don't we do them at 20?
Unlikely to provide.
Yeah, you're unlikely that there's going to have any kind of significant clinical outcome change at that point. So anytime we're doing screening for a child, it's because if we had an intervention at that point, it would make a difference. Remember, screening, not diagnostic. So if I'm going to do a screening newborn test and something comes back that is not confirmatory at all, I need to do something to follow that up. And then we'll go through a bunch of different examples. So typically in pediatrics, there will be a couple of different types. There will be screening questions, screening questionnaires, and then screening tests. So laboratory tests, hearing tests. So 2 different types of screening that we'll use. So a good example for surveillance is that you have a child that is coming into the clinic with a cold, they have an upper respiratory tract infection, they're 9 months old. So 9 months old, what are they supposed to be doing for gross motor? Crawling, they're mobile, they're somehow moving. What are they supposed to be doing for language? Yeah, that mimicking, ma, 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 da, da, da. So you're thinking this is a 9-month-old, they should be crawling around, moving, kind of saying ma, 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 da, da, da. They have a cold. You walk in the room, and that 9-month-old can't even sit up. Are you now concerned about the cold, if they're totally fine, or are you concerned about them not meaning anywhere close to normal development? Right? So your intention of that visit kind of shifts a little bit. So that's how surveillance is going to work in pediatrics. Our standard times where we're doing the developmental screening at those different well visits will happen at 9 months, 18 months, and 24 months at least. Why do we do them at those times? It's a trick question. Why these times?
Someone arbitrarily decided those times sounded good.
Someone arbitrarily decided those times look good, and so why do we care as providers then? Some for vaccines. That's when insurance is going to reimburse you. So those are the ones, you could do them for all of them, you won't get reimbursed. These are the reimbursable ones. And then autism, we're going to check at 18 and 24 months as well. So you can and should do surveillance and all of these screenings at any time. These are the ones where they will pay you to do them. One of the screening tools, so we will use, the DoD got rid of this a couple of years ago, but it is still, if something is wrong on our screening, I do a further screening with this one, so we'll talk about this. So the Ages and Stages questionnaires, or the ASQ. Many of you have kids and you've filled these out, it's like 27 pages long. It takes a while, but it looks at all 5 developmental areas. So we talked gross motor, fine motor, speech, language, personal, social, and problem solving. So it breaks down each of these categories. You can start all the way down to 1 month and up to 5.5 years old. So this is nice because when people, I've heard this before, people say, they're too young to do any type of screening. I'm like, really? Huh. Well, I can do screening down to 1 month. So we can get some of that. The other thing is we will correct developmentally if they were premature. So we are defining prematurity as how many weeks? Less than?
36.
37, yep. So if they hit more than that 37 and they're down into the 36 weeks, we'll give them that time back. So if the child is 7 months old, but they were born at 36 weeks, so 4 weeks premature, so which month ASQ am I giving them? The 6 month ASQ, okay? What if you had a 32-week premature infant? How many weeks early are they? 8. How many months is that roughly? 2. So if they're coming in for their 4-month visit, what ASQ are you going to give them? The 2 month. That's how you would do it, correct. What if they're 38 weeks? Do we do anything differently for them?
No.
Nope, not at all. So this is how the parents will score it. Because we're pediatrics, we don't just say, can you do the skill, yes, no. Yes or no, we'll say, yes, I can do the skill. That's 10 points. Sometimes I can do the skill for the child. That's 5 points. And not yet. We refuse to say no. Just not yet. That's 0 points. So for each of those, parents will say, yes, can they do these or not? We will add up those totals, and each of those domains will have a total. If you've read these or if you have children, it's really interesting. These were the ones that were statistically validated, but a lot of times it's really interesting. It's like, can your child put a Cheerio in a clear cup? You're like, what? And no one's ever done that, so they'll write no. And so there's a lot of times where you're trying to say, okay, well, what is this skill trying to get? Can they find something and reach for it? Or is there a fine motor skill? So there's times where I'll be like, they're like, nope, they can't do any of these things. And you're like, can they open your iPhone and call grandma? And they're like, oh yeah, they can do that. That's the intent. So you have to use your provider brain sometimes. But you fill that all. Parents fill that out. You fill it. You have each realm filled out, and then it's translated into this scoring section at the bottom. So the scoring section, if you are all the way into the white, you are good to go. If you are in the black, you are not good to go. That needs a referral to someone somewhere. That's not normal at all. If you're in the gray zone, you need to use your provider judgment. Were they premature and they're just a little early? Do they just need a little more time and we need to follow them up in a little bit? Are they right on the border? Should we go ahead and put a referral in today? So that gray zone said, hey, we need to do some more assessment and we need to use our provider brain there. This is what the military switched to. So when you go to your clinics, you will see this, the Survey of Wellbeing in Young Children, or the SWIC form. It's basically that just made really short to be able to screen further. So certainly if somebody didn't have all of these and there was a concern for this and you wanted to do, hey, which realm is this in? Then I would go to the full ASQ. But this is what you'll see on your rotations, and this is the quicker way to get that information for most normal healthy habitats. Your autism screening is going to happen at 18 and 24 months. So that one is standard, that one does not change. So this is going to be your MCHAT, which is the modified checklist for autism in toddlers, and then it's the revised one. So if you see MCHAT bar. There's several questions, but the 3 red flag questions are the ones that we are really, really looking at. So number 1, do you think that your child is deaf? And all the parents that have teenagers will be like, yes, I do think that my child is deaf. And you're like, no. As in, and what you're really asking is, can they hear? If a door slams, if their name is called, can they hear that? Do they respond to that? Or is there just nothing, no awareness? So I thought my child's deaf. Do they make unusual finger movements around his or her eyes? If any of you have been around children, they all do this. They all do, they touch their faces constantly in everyone else's faces. What this is looking at is really, is it a stereotypic self-soothing type of motion that they are doing near their face? So sometimes they will kind of do a repetitive motion, or that they're trying to do a self-soothing. Not that they're just all over you and everyone else. So that's really what it's looking at. And then, does your child get upset by everyday noises? And I hate that they use the example as a vacuum cleaner, because if you have a young child and you turn the vacuum cleaner on, I don't know, vacuum cleaners seem to get dogs and kids very upset. So what it's really looking at is, does a loud noise ruin the day? So if you've ever seen a child with severe autism, things like the hand dryer in a public restroom, the day is done, potentially. And so do these loud noises really, really disturb the child for a significant period of time? So if you have 2 of those red flags, or 3 of the total 20, that's really concerning. So those 3 questions are ones that we really, really pay attention to for autism screening. If that is the case, then they need a secondary referral to a specific type of pediatrician called a developmental pediatrician. So even I will send them to a developmental pediatrician for a full evaluation. These evaluations take about a half a day to a full day. So a developmental pediatrician is going to see 5 to 10 kids a week. So my last station that I was at, what do you think the wait was for a developmental pediatrician? A year, 4 months, 27 months to get into a developmental pediatrician. People would get assignments, be there for the assignments, and leave before they could even get into the specialty care. So really, when you're filling out BFMP paperwork, thinking, do they really need this specialty? Is there someone else I can get them to? Can I send them to an MTF? What kind of options do I have? Because sometimes the waits, especially in smaller places, are significant. Okay, well child exams. So this is the bread and butter of pediatrics. How many well child exams did I say they had in a year yesterday? 7. How many in the first 2 years? 10. When are they? You know when they are? 2, 4, 6, 8, 10, yeah. So that first one is considered your newborn visit. It's usually 3 to 5 days after you leave the hospital, and you have a standard 2-week visit. What do you want to do at that 2-week visit? What do I want to make sure they've gained back? Their birth weight. So you had 2 weeks to get your birth weight. What else am I getting that we got at 24 hours and we need to get a second one? We coach their little heels.
Bilirubin?
That's one. Bilirubin, what's the second thing? We coach their little heels. There's 59 of them in the state of Texas. Second newborn screen, that genetic screen. Yep. And then a bilirubin. So that's what we're doing at those 2-week visits. Then they come 2 months, 4 months, 6 months, 9, 12, 15, 18, and 24. 30 is your optional visit. So 2 to 3 is a long time in the lifespan of a child. So there's an optional 2.5 visit if you're kind of worried about them. Your vital signs would be standard, and then your growth charts as part of that to make sure, are they growing? Some sort of developmental screen. Remember, head circumference we're doing up until the age of 2. We're laying them down for length until the age of 2. Blood pressure, though, we don't start standardly until the age of 3. If you've ever tried to take a blood pressure on a 1 to 2-year-old, it's like trying to take the blood pressure of an octopus. Best of luck. Times where we will need that, we'll talk in cardiology, there are a few times that we need that. Right now, all I need you guys to know is standardly for well visits for most children, it starts at the age of 3. We'll talk more about all of the numbers specifically later in a different lecture. And then that head to toe physical, it's not going to be as thorough as the baby newborn one, but a full head to toe, because this child is rapidly changing, rapidly growing. So this, for those first year, strip down to a diaper every single time. Birth to 6 months, these are the ones that most of you guys, if you don't like or have children, you're like, I really don't want to do this exam. I'm going to break them. I don't like them. Stay away. This is the easy one. They can't run away from you. They can't bite you. They can't do much to hurt you. Right? So 0 to 6. Totally fine, and they're not fearful of strangers. They don't have stranger danger yet. easily comforted, and easily distracted. So these ones are some of my absolute favorite ones, so they don't talk back to me. 3 months to 36, these are the ones that'll bite you. This is like vet med. These are the ones where you gotta watch yourself. Otherwise, you end up with a dose of Augmentin for a human bite as well. Greater than 3 years old, they're really fun. They're talking to you. They're really honest. They're the most honest patients. You're like, does this hurt? They're like, no. Great. Glad we're good today. Some recommendations, I will always say to sit down, but with kids, getting lower than them so they're not afraid of you. Let the child sit with the parents. A lot of times I use the parent's lap as the table. There's no use in trying to force them on a table most of the time for these little guys. I don't wear a white coat ever. I don't use a tongue depressor under the age of 3. They just bite it and then it's useless. And I save the ears and the mouth for last. Because after that, all trust is lost. Apparently it's like nephrology. All trust is lost. When we're going to talk in general for all of these, we've already talked about newborn screen, heart disease, and hearing, so we are ahead of the game, but we're going to hit every single one of these. So, newborn screen, check, we got it. Hearing screen, if they fail it, they have till when to get to audiology? 3 months, yep. And that congenital heart disease screening, why do we use the right hand as part of it? Not bone age. What about the heart? It had something to do with the heart. What was the right hand? Preductal. Yep, you have your preductal saturation compared to your postductal. So they need to be no more than how many apart in percentile for SpO2. 10 is overall, so if you're less than 90, no more than 3 apart. Okay, fine. For infant and toddler then, when we start doing hearing and vision, we can still do hearing screens, they're not mandated though. Vision screens, we will start, and those will be validated down to 6 months. So we used to use the Snellen charts for everything, and then you try to get a 4-year-old or 3-year-old to read a Snellen chart, almost impossible, or impossible. So now it will take a picture of the outer cornea of the eye and look at astigmatism for you, give you a picture, give you a reading. Down to 6 months. So we can start vision screening down to 6 months. And then anemia screen. Why do we do an anemia screen at 12 months? What nutritionally do we have them do at 12 months? So they're eating solids, they're eating more solids. What are we switching from and to? Cow's milk. What does cow's milk not have in it? Iron. So that is why we do this at 12 months, because that is the time that if they are already anemic, and now we take them off of formula or breast milk that has iron, this would be a point of intervention that you would need. That is why we screen particularly at that 12-month mark. You can get a CBC, which is a venous puncture, or you can just get a heel stick, that's just the H&H, or a finger stick. Lead, so this one, people miss this one all the time. Lead is going to be with a lab at 12 months. So you get a CBC or an H&H and a lead screening, because where do you see lead? Classically. Paint. Yes, so old homes, right? So I see that one on the pants prep questions all the time. They'll say, family bought this house that was built in 1912. The kids crawl around outside, and now they're starting to act funny. What could this be? Right? So you're like, are you eating paint? So that's the thing. So they're putting everything in their mouth at that age, so CBC and lead. The other part, in the second half, is that they get screened with questions up until the age of 6, up until the school has been established. So different lab versus questions that they get at every well visit. Tuberculosis is just questions, unless they have significant risk factors. So only questions, so they do not need PPDs, they don't need quantiferons, you're not getting any kind of labs for them, and you have to use your provider brains for this, because they might screen positive because they have a healthcare worker in the home. But if you're like, tell me about this healthcare worker, and they're like, my aunt lives with us during the summer and she works at the school as a 3rd grade nurse, you're like, little bit different than if someone's in the ICU and in a prison hospital with high levels of exposure, something, right? You're going to use your provider brain to say, is this truly a high-risk kid that needs other testing for? So think tuberculosis with just your screening questions. And this one everyone misses too. So for every kid, every single child will get a non-fasting lipid panel between the ages of 9 and 11. What happens roughly to most kids 11 and up? Puberty. Yes. What happens? What kind of things do you get coursing through your body during puberty?
Steroids.
Hormones. Yep. Hormones bind to your sex globulin proteins. Those ones cause your cholesterol and your lipids to be lowered. So teenagers, where they have these hormones coursing through their body, have the lowest lipids of anyone around. So you have to get the screening both before puberty starts and then after. You get it while they're teenagers, you get a falsely lowered reading. So who's not going to see this patient often, 17 to 21? I'm not going to see them anymore. So this becomes on you guys as your primary care people to go ahead and get that screening lipid panel at this age. So my poor clinical group, I will probably ask you 100 times for preventive care. Just say this one. Just lie to me. If you have a patient where you know the parents have early heart disease, the parents have cholesterol that's above 240, you should be screening that child at the age of 2 to see if there's a genetic component of that. Okay. That's for all kids. So, let's see. Check just to see where we are. A 4-month-old comes in for a well check, and during the examination, you notice that the child is rolling unassisted. Are you concerned?
Yes.
Why are you concerned?
It's 3
Or are you not? 4 months old. Are we supposed to be rolling at 4 months old?
Yes.
Yes. So are you concerned?
No.
Nope.
3.
A 15-month-old comes in for a well check, and during the examination, you notice that the child is not walking independently. Are you concerned?
Yes.
How concerned? Yeah, they should be doing this right around between 12 to 15. So is this like if they were, what if I said that was that same child and now they're 18 months old and not walking?
Very concerned.
Now I'm very concerned. Now I need to do something as opposed to, let's follow you up in a couple weeks. 6 months comes in for a well check, and during the examination you notice that the child is unable to say any words. Are you concerned?
No.
What are they supposed to be doing at 6 months?
Babbling.
Babbling. Right? So are you concerned they're not saying any words?
No.
No, not concerned at all. So these are the ways that those developmental questions will get asked. Do you know what's normal and not normal, and what you would do if they're normal or not normal? Do you give reassurance? Do you tell them that they're developmentally on track? Are you concerned and a close follow-up, or do you need to have intervention that day? A hot topic.
Spicy.
How much time? 10 minutes. Okay, immunization. My caveat to immunizations right now is that this is a hot topic everywhere. So we're going to talk about what children are eligible for, not what is required or recommended or anything like that. What is somebody eligible for based on the safety profiles right now? As a reminder from probably micro or ID, when we have active versus passive immunization. So active immunity, the child's body is making that immunoglobulin or IgG from having the exposure to the vaccine or a toxoid versus your passive immunity. So passive immunity you're getting from mom, you're getting from antibodies, you're getting from certain like a rabies immunoglobulin would be a passive immunity, things like that. Your primary prophylaxis is when it's the first time you're seeing that versus secondary prophylaxis. Parents are going to call those booster shots. The booster shot, we would now call that secondary prophylaxis. Please do not memorize this. Do not memorize this. This changes every single year. So, and at this point it's changing
Rapidly.
rapidly, yes. So this was 2025's. They had not released a 2026 yet with the updates. And so this is available through CDC, it's available through ACIP, it's available all over the place for what is recommended at what time. So it'll tell you which dose and how often, how many they're going to need for that. The granularity of that is not as helpful to me. So on the second page of that, when you look it up and it tells you the specific immunization, it tells you the first dose needs to be, the child needs to be at least this many weeks old, and then the second dose needs to be at least this many weeks after, so that you can calculate that. I do not let any kids get any shots early, ever, because I've seen schools do crazy things. So one time I had a school, the child got their immunizations the day before their 4th birthday, and the school would not accept them and made them re-get their 4-year-old shots for one day. Do you think that their body and their immunity changed from one day? Not at all. Would they allow that child at the school? No. Is it worth the fight? No. Do children need multiple immunizations like that? No. So I, as a provider, just don't let them get them early to prevent having to re-vaccinate for no reason. So, but up to you how you want to practice, because there's difference in the minimums versus what places will require. This one's interesting just so that you've seen it. So these ones are if there is a medical indication. So if you have a child with something like sickle cell disease, something like asthma, where they might have additional recommended vaccines or slightly different timing of the vaccines, there are secondary charts to help you for those different medical indications that are not on the standard charts, to just be aware of them. PSA break here, when you go out into your different units, a lot of times they'll say, which kind do you want to order? There's a whole bunch of different types. DHA is working on standardizing it, but it is still not standardized. So you will often have to know which brand. Is this a 2-dose or a 3-dose series? Is this combination or not combination? So when you get to wherever you're going to be assigned, make friends with your immunization clinic so you at least know what's available to your both adults and child patients. Preterm infants. So we said the only vaccine that could be offered at birth is what?
HPV.
Your Hep B. Yep.
Hep
What's
B.
the other poke they get in their other leg?
Vitamin K.
And what is vitamin K helping prevent? Bleeding. Yep. Dumb name. Vitamin K deficient bleeding. Hemorrhagic disease in the lung. They should be on the same schedule. So preterm infants, as long as they are 2 kilograms. So if you had those very low birth weight infants or extremely low birth weight infants, they won't qualify for that. But does pertussis know that they were premature, and will pertussis stay away because they were premature? No. So while we adjust for prematurity for things like growth and development, we do not adjust for vaccines. We give them chronologically as long as they are 2 kilos, because again, pertussis is not like, oh, well, you're premature, I won't come after you. And so that is why we give them those times. So Hep B, the one that would be offered at birth, if mom is positive or if there is a status that's unknown, they would both get the vaccine plus the immunoglobulin. The other things that I don't need you guys to memorize are all of these things. I will tell you on these, know this part, know that part. I'm not going to ask you how many doses are in a series and at what age you need to get that. You're going to look that up every single time. Okay? So the things I need you to know. Hepatitis is the one that they could be offered at birth. That's what I need you to know. The other 2 doses happen within those first year of life, for the most part. DTaP. The thing that I think is interesting about this is that when you are little, you get more diphtheria, less tetanus. When you're 7 and above, it switches. You get more tetanus, less diphtheria. Pertussis is always at the end. So you get several doses of that. And then a Tdap shot when you're 10 or 11 and above. Hib. Hib changed our practice in pediatrics a ton. So Haemophilus influenza type B. So you are going to see Haemophilus influenza for your entire career and you're thinking, I have vaccinated against this. The vaccine is against a specific type B, that has specific antigen markers that are preferential and give you significant disease. So it is not for all types of Haemophilus influenza, specifically type B. IPV and polio. How many of you are 80s babies in here? Oh, not that many of us. This is sad. Okay. You go home and look at your immunization cards, if your mom still has them or if you have a copy when you were little. You might see OPV instead of IPV. Now what does OPV mean? Oral polio vaccine. And what are those oral vaccines? They're live vaccines. Right. So we used to give oral live vaccines. And what happened is that polio was eradicated. At some point, we were giving more polio to people than we were protecting against. There was one year that the oral polio live vaccine gave 12 cases of polio when there were none that were nascent cases. So they switched in the early 90s to IPV. So some of you 80s babies might have had the oral polio. It is now inactivated and in the direction of polio. Measles, mumps, and rubella, you cannot get that separated. So sometimes parents will ask, I just want measles or I just want rubella. Does not come in a form that's not MMR. It was studied that way, and that is the way that it is. What is interesting about MMR? It's the first what kind of vaccine that they get injected? It's the first live one. So the first one that they're getting injected. Meningococcal, a couple of different types. So your B is your 2 dose different types, so depending on where you have, but a couple of those. A, see what else do I want you to know? Influenza, so it'll start down to 6 months. This one's different because in your first year of life, you need 2 doses. Never again are you going to need 2 doses of that. So that is why that one is specific and different. Please know that. Your pneumococcal, when I started in medical school, they said, oh, the pneumococcal is for everybody. It's pneumococcal 7. How many strands of pneumococcal do you think that one covered?
7.
7. And during residency, they said, oh, pneumococcal 13 has come out. How many of the strands do you think that covered?
13.
13. What is it now?
20 million.
Pneumococcal 57. That's me. Pneumococcal 20. So we are covering 20 strands right now. There is also a pneumococcal 23 that can be given. Varicella, so chickenpox. How many people had chickenpox in the room? Does anyone have it? Oh, good. Okay, so you guys aren't children. So chickenpox, it goes when they are 4. This can be combined with MMR. So it's another live vaccines. MMR be at the age of 10. HPV, the ever controversial one for oral, anal, cervical cancer, and penile cancer. So not just cervical cancer, but it's for HPV, obviously. And this one, it is as young as 9, but it is licensed up to, does anyone know how old?
45?
45, yes, exactly. So you through your 45th year, so you can get it up to 46. So all of you haven't had it, go protect yourselves against cancer. Rotavirus, this is the one I need you to know too. It is the only one that is oral in that first year of life. So it is an oral vaccine, meaning that it is a live vaccine. So it's your first live vaccine compared to your first injected live vaccine that was MMR. And is the only oral vaccine. And then they added the RSV vaccine. The interesting thing about this one is this one has some passive immunity. It's a monoclonal antibody that you are getting. If mom got it, baby doesn't need it. If mom didn't get it, baby needs it. So it's a specific immunization. Last one, then we'll take break. So contraindications. If they anaphylaxed before, don't give them another one of that same thing they anaphylaxed to. Use your provider right there. If they are immunocompromised or pregnant, as teenagers, please don't give them a live vaccine. The rest of them are not contraindications. They're just precautions that your provider brain is going to have to determine. If they're ill that day, so some families are going to say they're already sick, let's get it over with. You actually are going to get a more robust immune response because their immune system is already primed. There are other families that are saying if they're sick that day, I don't want that shot at all today, so they're well. So you can go either way. Breastfeeding, not a contraindication. Prematurity, as long as they're over 2 months of age, not a contraindication. If they've had some significant other allergies, but not anaphylaxis to this, so say something like penicillin, something to think about. And then yellow fever is still a contraindication if they have an egg allergy. Otherwise, an egg allergy is just something to note and be aware of. None of those are contraindications, just things to use your provider for. We will come back at 2:02. Are there any predisposing factors for moms that would give them that breast milk inhibitor? I have no idea. Dr. Love didn't know either, so I did myself a clinical inquiry and went down. So I found a couple of things for you guys. So gestational or type 2 diabetes have a higher amount of the enzyme that can unconjugate that in kids. Hormonal factors, so moms who had just a general higher level of progesterone, one of the metabolites, could do that as well. And then moms who had obesity, their non-esterified fatty acids also contributed to that. So there's multiple things that predispose you to that. So in general, if you had a mom with diabetes or obesity, going to have an increased risk of having breast milk jaundice versus breastfeeding jaundice. So thank you for having me do a clinical inquiry. I look forward to hearing all of yours. Never start a series over. So if they're like, I got this one shot at 2 months, and then we were anti-vax for a year, and now I think I'm pro-vax, or I want some of them, or whatever you are, it doesn't matter. Don't ever start over. So there's catch-up series for everything. The risk versus benefits, you will see things over the course of your career. You will see different studies. Ultimately, there is still a risk versus benefit that favors immunization against these communicable diseases. All of them are because these cause pediatric deaths. So, for example, the death total for pediatrics for the flu this year is up in the higher 30s at this point for flu A. So everything we're vaccinating for ultimately can kill children from something. The school systems are still mandating them, probably more to come with that. No vaccine is going to be 100% effective. No vaccine is going to be 100% safe. So risks and benefits for those, and talking to that with the family is going to be important. And then VAERS. What does VAERS stand for? Yep, Vaccine Adverse Event Reporting System. That is looking for trends and tracking. So you're not looking for something specifically for causation, you're looking for correlation. So if we started giving a new vaccine and then everyone started losing their sense of taste, oh, that's how we're trying to correlate things. So it's just a large data collection for correlations. The schedule is going to change every year, so again, please do not memorize that at all. And most importantly, now you have this shared decision making with families. So these are the things that are offered. Families much more part of the process than probably years past. Okay, safety, counseling, and risk assessment for part of this health maintenance. There are charts. There are lots of charts. I'm going to tell you specifically what I need you to know, so please do not be overwhelmed and throw tomatoes at me based on the charts. I'm going to tell you a story too, because I was traumatized, and I don't want any of you to be traumatized from that same thing as I fall off the stage. So, my very first question on my pediatric board exam, I had studied, I had done all the practice questions, I was ready. First question out of the gate said, what is the maximum temperature that a water heater should be set at for pediatrics? And I was like, what? Like, this is like a random factoid, right? It's in your book. So we're going to learn this together. At the newborn visit, you should recommend to parents that they set a water temperature of no more than 120 degrees Fahrenheit. I don't want any of you to miss this question on the pants. This is probably just a factoid that I want you to know versus anything else, but it was on my boards. I want you to know. 120 degrees. Why do you do it at the newborn visit? You're really worried that a newborn is going to go and suddenly just get the bath water? Sure, baby will be safe if you're bathing them, but also, do you think that that parent's going to remember, oh, I should do this when they're 15 months old and that kid's just grabbing the hot water? Probably not. So if you go ahead and set it when they're a newborn, it'll be fine throughout the time that they are kiddos. But something to think about for this PCSing population, making sure that if people are moving in and out of homes, that their water heater is at a safe temperature for them. The other one that I want you guys to know, sleep position. So on this chart, all the way down, so 0 to 4 months, we want kids to be back to sleep, meaning put them on their back, right? If they are under 2 months old, we know they don't necessarily have that head and neck control to protect their own airway and move their head. We want them on their back. Well, that's a terrible sound, so sorry. What else do I want you guys to know? Introduction of solid foods. Yesterday we talked about that, to have that discussion at 4 months. Okay, so those are the ones. Hot water heater, back to sleep, and introduction of solid foods. When we're talking about why do we want to do back to sleep, we are trying to prevent SIDS, so sudden infant death syndrome. And we have to define that as a couple of things. So it has to be an infant, meaning they are under that 1 year old, and it has to be completely unexplained after you've done a full autopsy, full investigation, and all of the different labs. It's a diagnosis of exclusion. So you would never say, this child died of SIDS because they had maple syrup urine disease. Or this child died of SIDS and they had this genetic XYZ, right? Or congenital heart. If you have SIDS, it's a diagnosis of exclusion, so you don't know what was causing it. Still a leading cause of mortality, but it went significantly down when we started having kids go back to sleep. So when we say that, the Back to Sleep campaign was not just that we want them on their back. Sweden did a really cool thing. They handed out literally cardboard boxes to families, and they're like, have your baby sleep in this cardboard box. And their numbers were fantastic from babies in cardboard boxes, because it fit all of these things. We wanted a firm mattress that didn't have any incline or decline to it. We wanted the same room but not the same space. When I was in residency, I saw it a couple of times where parents had fallen asleep with their children, had rolled over onto the child, and hadn't woken up and suffocated the kid from rolling onto them. So sometimes when pediatricians jump up and down and say, don't do this, and people are like, dear God, I just want to fall asleep, it's because we've seen the bad outcomes of those things. So, same room, but not the same surface. No loose bedding, loose objects. So again, think baby in a box. You wouldn't necessarily stuff the box with a whole bunch of bedding or crib bumpers or any of those things. Avoiding smoking and nicotine. We do want some tummy time to work on that head and neck development over time. We don't want them too hot or too cold, so overheating can be a concern. It's not recommended to use home cardiopulmonary monitors. So if anyone's heard of the owlets, it's a big thing for a while that families were getting. It was kind of a cardiopulmonary monitor that was at home. The outcomes didn't change anything. So when you looked at what the numbers of SIDS or the numbers of times that people called ambulances or went to the hospital for things, the outcomes were no different. The thing that went through the roof was parental anxiety. So it just made parents a lot more anxious, but it didn't actually save any babies. And then always prenatal care and avoiding drugs is going to be the biggest ones. So things, and then the last one, this one's weird. In the studies, offering the pacifier changed the outcome for SIDS. Even if the pacifier fell out, if they started the night with a pacifier, the outcomes were different. So I think that's really weird. I can't figure that out.
Better? Or?
Better.
Okay.
So if they were offered a pacifier, overall lower SIDS. What happens though when you have a child who has open sutures, who is laying on their head all the time? They end up with plagiocephaly or positional plagiocephaly, so that flat spot on their head, laying in that same position. So usually you see it if they're not on their tummies or getting some sort of tummy time. It's the worst at 4 months, because at 4 months, what are they supposed to start doing?
Lifting your head up.
Head up and rolling, right? So once you can roll, you can get your head off of this just laying. The evaluation should be, I have a flat spot. I also need to evaluate that sternocleidomastoid for some hypertonicity if there's a torticollis involved in this. Most of the time they're going to approve if you did nothing, just because the baby's rolling, the baby's spending more time upright on their tummy. That's what you'll see most of the time. Certainly want to encourage tummy time and having early intervention for physical therapy if you're suspecting any of that torticollis. If it's really no improvement and they're sitting up and you've done all of those things, one of the things you can think about is a craniofacial specialist. I would say the outcomes from helmets really didn't change over time. The helmet didn't actually improve the outcome, and it caused a whole lot of dermatologic issues and superficial infections. Also, TRICARE doesn't cover it no matter what you do. So just to be aware, insurance doesn't cover it, and your outcomes weren't statistically that much better. Torticollis then, so you're looking, is there positional plagiocephaly, and do I have a shortened sternocleidomastoid on one side or the other? If I have a shortened side, my head and my eyes will be going away from the side that is actually hypertonic. So things to do for that baby, sometimes I think it was in the last slide, switch the crib to a different side so that if they're looking for visual stimulation or looking for the parents, they're forced to go to the other side. Also with some stretching and some passive range of motion issues and movements with physical therapy can help a lot as well. So torticollis, secondary to plagiocephaly, secondary to that fast asleep. The other thing that we wanted to do for babies, as part of that safety guidelines, is how do we transport them? So things to be aware of is what are the current guidelines for transporting or passenger safety. So it used to be really easy because it was keep them rear facing until they're 2. Now it's rear facing as long as possible as per manufacturer's guidelines of the car seat, which doesn't really fit nicely on any kind of slide. So rear facing for children that are young. Let's see, what else do I want you to know? Booster seats until you're 8, and no front seat until you're 13 or older, which I'm pretty sure I was in the front seat of the car way earlier than 13, but that is the recommendation. Always a lap belt. Yeah, the big one is as long as possible, look at what your car seat says or your patient's car seat to determine how long and what they are rated to for weight-wise. This says the exact thing. I'm doing it right now. Your tobacco smoke, we want to, I don't think there is really anything that we have talked about at IPAP thus far where we say you should really smoke. It's really great. Same is true for kiddos here as well. So it's going to have some issues with having smaller infants, increasing your risk of SIDS in general, all of your respiratory and heat type infections, asthma, even if they're smoking outside. So the recommendation for parents to cease smoking once a child is there. For your 9 to 18 months, in general, the big takeaway is you are mobile, but you do not have a whole lot of expressive speech yet. So that can be a scary combination. So anything that's going to have some sort of safety where they are safe around water, they are safe around firearms, they are safe around the streets, they have supervision, is going to be your most biggest piece for safety here. So that's the main takeaway at this age. The other ones that I specifically want you to know, 12 months introduction of cow's milk, and that you need to get that H&H screening there. Those are the big ones. Talking right around a year about discipline too. So thinking safety because they're mobile, so what is in their reach, child proofing, and then that milk at 12 months. Those are the biggest ones I want you to know. This is also around the same time they're going to get some teeth. So it is normal to get teeth down to 4 months. It is sometime between 4 months and 15 months. So there are sometimes they are talking to you and they're still gumming it up and they're telling you like, I want some juice, and they got no teeth. These other ones, these little 4 and 5 months olds that are already got some things going on. So you can see both. If they don't have teeth, they have not erupted hypothyroidism, organ differentiation and metabolism. So that's your go-to for that as well. Things to think about. Permanent teeth are going to start usually around the school age. So late kindergarten, early first grade, basically through the school age years. So kindergarten through 5th grade is most of the time where you're going to see most teeth falling out. The reason that that's important is that if teeth fall out earlier than that and parents don't have a story that makes sense, that would be an indication, is there some abuse going on? They're saying, oh yeah, they just lost this tooth at 3. Well, you know that's not normal, so how did this kid's tooth fall out? What was happening that they had that? Happens all the time, got hit in the face, fell down something, like kids, that happens, but make sure that the story makes sense. And they're not just like, yeah, the tooth fell out. Totally normal. That's not normal. What are the guidelines? The guidelines are once you have teeth to be starting to see dental and to have a dental home established by the time they are 1. So we want to make sure that they get early fluoride administration to prevent these cavities. And again, that they have a dental home and routine established by the age of 1. When they're teething, the recommendations are to have as much pressure and a clean finger along the gum as possible, both for comfort and for cleaning the gums as the teeth are coming in. Avoiding sending a kid to bed with a nighttime bottle for a couple of reasons. Number 1, the continued use of the nipple will change the angle of the mouth and can cause some longer term damage. Depending on also what is in the bottle, is there's going to be glucose that are just sitting on the back of these developing teeth, leading to some significant caries. We'll look at a couple of pictures of those. Please, for the love of God, don't put juice in a bottle. Juice in a bottle at night, worst of all the worlds for me. Fluoride intake. So I think the recommendations for this are incredible. I put something that made sense, a schmear. The actual recommendation says that you should put the amount of a grain of rice of fluoride toothpaste on a toothbrush, and I don't even know what that means. Like the amount of a grain of rice, like what kind of quantity is that? I don't know. So a small smear, pea size, and then a regular thing of toothpaste. Assisting until they can do it. So you want to put juice in a bottle at night, you will end up with baby bottle caries and a young child whose mouth looks like this. So please, for the love of God, don't do that and have your patients highly recommended against doing that as well. If you have to do the bottle, ideally you're doing a sippy cup, and ideally it has water in it. It's a short and firm thing for the cup as opposed to a more flexible and longer nipple. Okay, you're a little bit older kids. Now in your toddler age, a couple of things that I want you to know. So 2 years old, that's when you should be thinking about toilet training and having that discussion. So potty training right around the age of 2. Remember, that's also the age if there are significant family issues that we are going to want to get that early cholesterol screen. What else do I want you to know here? And getting ready for school. So reinforcing school habits that 4 to 5 year old. Booster seat at 4. Toilet training, booster seat at 4, getting ready for school. Those are the 3 that I want you to know there. Things to talk about with families is what are they going to do for discipline? So a lot of times people will ask you parenting questions, so at least knowing what some of the recommendations are can be helpful. So the majority of recommendations are that you want to teach self-control. It's not just to punish a child. So the idea is that kids are not bad kids, they just maybe did a bad thing. So you want to avoid using things like you're a bad kid. So reinforcing the good, to limit the bad with self-control. The AAP does not advocate corporal punishment. If families choose to do that, they should at least just know what the upper and limit boundaries of that are to have a discussion with that. We'll have a whole lecture on child abuse that we'll talk about that with. Most of the time, we are going with a balance between we need limits, so whatever the parents are going to set and sticking with those limits. So sometimes you'll watch parents, they're like, I'm going to count to 3, they count to 37, and the kids are still running them up. So we're focusing on setting limits that are appropriate for that age, temperament, and developmental level. So anything that is a punishment should be very brief and very direct on that behavior. So you can't come back the next day or a week from now and be like, remember that thing that you did to your 2-year-old? Totally lost. The 2 ways that are recommended are both extinction. So if it is a harmless behavior that's mostly annoying to the families, the idea is to ignore it. Certainly if it is harmful to them, that would not be indicated. So this is for harmless behaviors. Option is either to ignore, which is the extinction technique, or the timeout. So really timeout does not start until you are 18 months old. And children have 0 concept of abstract thinking. So if you think that a child is going to go and think about what they did, they don't get abstract thinking until about the age of 10. So they're not thinking about anything. You're just trying to de-escalate and remove from a situation. And timeout should be no more than the age they are years old. So an 18-month-old, 90 seconds max. 2-year-old, 2 minutes, 3 minutes. And they're again not thinking about what they did. There's no thinking. Your school-age children, so most of the time you're talking about school-related programs. Are they able to articulate if they're being bullied, if something inappropriate is happening? Biggest thing for the 11 to 13-year-olds is as you're getting them ready for puberty, are they aware of what is about to happen? So having those discussions about puberty, about what is going to happen, and about what they might start to experience. So. A little bit older kids, once you're in those teenage years, those are the ones that you're really looking at their risk stratification. So this is when they have all the risk taking in the world without a lot of prefrontal cortex to help them stop making these decisions. We were all teenagers once, we know what that means. So these are some of the things to discuss. Discuss their alcohol use. Discuss any type of drug or exposure. Discussing what safe sex looks like to them. Making sure they have STD testing available, contraception available, that you've had those discussions with them. Are they driving? Are they drinking and driving? Do they wear seatbelts? Are they being beat at home? We have a whole adolescent lecture to discuss some of this, but the risk taking and the risk stratification is the most important thing here. 14 to 16. 17 plus, you start to be talking about what is your plan? Do you have a plan to support yourself? Do you have a plan for college, for a job, for some sort of employment? What are you going to do to establish your healthy lifestyle as an adult? And at 17 plus, what other lab do you need to get? 17 to 21. Those lipids again. Yes. Good job. Okay, check on learning. What gross motor skill starts at 3 months? 3 to 4 months. Gross motor. Rolling at 4. What else? Their head up. Yep. What should their chest be doing as well?
Push-ups.
Kind of up dog, baby yoga. What is the age that the child needs to be in a car seat?
4 years?
4 years old. Yep. So rear facing as long as possible. Car seat till the age of 4. Booster seat till the age of 8. How should they be sleeping? Up to 4 months old. On their back. Yep. Baby in a box. What age do we screen for lead? Trick question. What age do we screen for lead with labs? 12 months? Yep. What else do we get at 12 months?
Bunch of vaccines.
Iron. Yep. And H&H. And then how long do we do questionnaires for lead? Yes, through the age of 6. Those will be how these type of questions are asked as well. We have 20 minutes. start 5, so I want to get through as much as we can so that we have easier weeks. You guys can get out when really your souls have left your bodies. They're only partially left right now. I'm telling you, by block 3, it will be like a mutiny against all of us. Like, straight mutiny. Okay. So, at this point, that is half of the information for block 1. You are done with half of the information. You got the normals. Okay, so now we had newborn. What's a normal newborn? What's an abnormal newborn? What is normal growth? What is normal development? So that is where the first half of the block is. We then start talking about what happens when that growth and development isn't normal. So those are the next 2. Then adolescent, and then child abuse. And then the block is done. So that's where we're going in the second half. So what happens when our growth now is not normal? Again, still falls under health maintenance. If you're wondering why I picked these particular genetic disorders, it's because the PANTS picks these ones. So I don't know that I would always agree with some of these, but we are going to go over these because your PANTS says that they are testable material. Okay. So your textbook says the definition for failure to thrive. The new definition of what people are calling that is growth faltering. So when you go on your rotations, you will likely probably hear growth faltering, but you are held to what your textbook has, and that is what is on your PANTS blueprint, and so that's what the PANTS is still going to test your class on. So I want you to at least heard them both. So failure to thrive is the same as growth faltering. In residency, we had a hashtag in the days of hashtags, where it was just every time we messed up as residents, we put hashtag failure to thrive. And it was just an entire thing of that. So I will miss the days of calling it failure to thrive. So it is when a child does not meet their growth expectations. This is the actual transformer part of their body, not their development. So this is the size of their body. So that's the biggest thing. So this is developed by or determined by your growth charts. Most of the time, this is going to have something related to a malnutrition, and not an intentional malnutrition, but a malnutrition where their body cannot absorb correctly. Can be environmental, psychosocial as well. Things that we look at. Most of these are going to be non-organic processes, meaning that there's not an underlying medical condition. So this could be the family member that they were doing breakfast, lunch, and dinner. There was nothing wrong with that child's gut or absorption. The family simply didn't know. Okay, so that would fall in those 2/3 category. The other third of the category is going to have something anatomical or physiologic that is going to be that underlying cause of failure to thrive. The body is not growing correctly. So we will define this as any one of these 3. So either, and this is not fair to you, I'm going to use the 3rd percentile. Weight that is less than the 3rd percentile or the 5th percentile. There's no consensus of that in PEDS because we use normal BMI as 5 to 85. People are like, well, why don't we just say less than the 5th? And it's really because of the standard deviation, and 2 standard deviations away takes you down to the 97th or less than the 3rd. So it's truly 2 standard deviations away. So by math, I'm going to use math, right? So I'm not going to give you something that's like in the 4th percentile and ask you about that. I'll give you something way less than that. So use the 3rd percentile. So if your weight, I'm giving you a growth chart, and the weight is less than that 3rd percentile, that could be a definition. You would meet this. You could diagnose failure to thrive just with that, or growth faltering. If you cross those 2 percentile lines at any point, that would be a second definition. And then probably our least often used is if your weight is less than 80 percentile of median weight for height. So when you're using those proportionality growth charts, you're seeing that it's less than 80% of that. I would say the majority of us are using less than the 3rd percentile or crossing the 2 percentile lines. You're going to make sure that your weight is adjusted for prematurity. They get that 6 months of catch-up growth. And we're looking at it obviously holistically, not that one snapshot in time, but what has this child been doing over time? Really, we said that growth is that luxury of nutrition. So if they don't have it, they cannot grow. So most of the time, it's coming from an insufficient caloric intake for this baby. So do they need more calories? So that's an option. So things like congenital heart, if you think about what Dr. DeVore taught you, those babies are going to need more calories. So do they just need more? Can they not absorb the calories that they're intaking? So things like celiac disease, inflammatory bowel disease, can they not absorb and they're taking in appropriate amounts? Or can they not process it? Do they have something on a newborn screen, an inborn error of metabolism where they can't break something down, like galactosemia, phenylketonuria, something like that. And they are malnourished from that. And then are they just not taking enough? Think about breakfast, lunch, and dinner baby. So type 1, I'm going to ask you about one of these types. So type 1, 2, or 3. So start this slide. So wasting is if you are type 1. So this type, the only growth chart that is affected is your weight. So you are still growing in length, your head is still growing, but your weight is not changing, or your weight is not sufficient to keep going. That is typically seen as the wasting type of malnutrition type. The next thing to go, so everything in the baby's body will shunt calories preferentially to the brain. So now we're not gaining weight, we're not gaining height, but our heads are still growing. So now you have the stunting type or linear growth. So this you typically see it's either a long time or in some chronic and severe diseases that have started to arise. But I really want you to think of that one as it's been a long time. So most common, you're going to see just the weight. Next, you're going to see type 2 stunting. If you see symmetric or type 3 growth faltering, you know that it's either been so long that their head can't even keep up now, or more likely they have an underlying chromosomal abnormality or something congenital that has caused all 3 to not grow appropriately. So those are your two options. It's either been a really, really, really long time and very severe, or something congenital, something genetic. I'm going to ask you about one of those 3 types. So if we're looking at this growth chart of this little human, is it a boy or a girl?
Boy.
It's a boy on your growth charts. So they, let's say they're twins. So this top child, they came in at about the 50th percentile. They always stayed inside of those percentile lines, and they just kept growing normally. Totally fine there. This second child here below started at that 25th-ish percentile, and this is where they crossed 1, and this is where they crossed 2. So at the very minimum amount, we should have caught that at that 4 to 5 month mark, and at that 4 to 5 month mark is where we would have said we've met the definition of failure to thrive or growth faltering. This is just the weight one, so we're calling this type 1, 2, or 3 right now. Type 1. Yep, wasting. What happens next? I don't understand. I don't understand why something wasn't done at 6, 7, 8, or 9. Okay, but when you see that as soon as they had calories input, they took off again and they ended up pretty close to that same percentile where they would have started. So that doesn't always happen, but that can happen. This was one of my patients almost exactly. So I had one just like this. So your question then is going to be, can I send them home or not? Does this need to be an outpatient thing that we deal with, or do I need to send this child to a hospital? Most of the time, this doesn't happen overnight. So most of the time, you're going to leave this child as an outpatient. Inpatient. I do this if it's super severe, meaning we're in that stunting type, or we are in that symmetric type, and I don't have a good explanation. There are underlying diagnoses where I think that we need inpatient evaluation. So if they say, I can't do this outpatient, they need a colonoscopy and an endoscopy, and they're small, like 6 months old, I need to sedate them, so we need to put them in the hospital. It's a They need that evaluation. If I think this is due to abuse or maltreatment, that would be an indication. Always you can admit for that as the provider. Or if they've failed outpatient. So that's probably the biggest one that I want you guys to star. So if you have a compliant family, they've come for weight checks every week, they went to GI, they went to nutrition, they went to lactation, they did all the things, and the child still isn't gaining weight, that's when you can also say they have failed outpatient and I need to put them inpatient to be able to control and calculate what's going in and what is coming out with direct observation. I'm going to have a couple of outcomes. So if they're inpatient and they feed just fine. So I had this family that was compliant and they're doing all the things. They get into the hospital and they gain weight exactly like they're supposed to. So let's say they're in those first couple of months. It's a 2-month-old. How much should they be gaining a day? How many grams? 15 to 20, so about an ounce a day. So if they're gaining about an ounce a day at that amount, then you can deduce, hey, something probably isn't going well at home, or the way they're feeding isn't going well at home, but it's a feeding issue, not something with a gut or not something with a malabsorption process. What about they're feeding normally, they're taking normal ins, normal outs, and they're not gaining weight? That's when I start to think there's an organic cause. Something metabolic, something endocrine, so most likely my first guess is going to be what? Hypothyroid, yep. Or there's something with a malabsorption degree going on. My third option is that they actually can't feed well at all in the hospital. So now they have choking or aspiration or vomiting or significant diarrhea. And then I start to think, is there something going on neuromuscularly with the suck, swallow, breathe reflex? Is there something going on in the GI tract? Some things like that. So ultimately, history is going to be what you use most often, inpatient, for those cases where you're really trying to determine what is going on for those kids. Finish this section. Let's try to finish this one little section and then we'll stop. So this evaluation of this, always with a history, I need to know what that birth history was. So when you're thinking for all of your claim court cases or in anything on your rotations, when you ask past medical history for children, you need to ask their birth history as well. So it's just another category of history to ask. So prenatal and birth history. What have their milestones been? Do they go see a provider? Have they had well checks, and how have those well checks been going? Are there known childhood diseases? I had one family where they're like, nope, everything's good. There's a teeny tiny little kid, and at some point it came out, oh, we have celiac. I'm like, well, that's helpful. I'm like, thanks. So sometimes families just won't tell because you're not asking the right question often. And then social history. Have they PCS'd 4 times in the last year? Is dad deployed? Did mom and dad just get a divorce? What's going on that there might be a social factor as well? Your vital signs and growth charts, you guys are doing really good at reading those. Your exam, head to toe, is going to give you some of those clues. I don't need you to know this. I'm not going to ask you something specifically, but just to think in general. If a child is spitting or vomiting, or refusing to eat, most likely an upper GI tract. That should make sense, right? Do I have a reflux issue? Do I have EOE or something going on upper? Diarrhea or fatty stools? Fatty stools should make you think immediately of what? Diagnosis in a child. Oh, this is on advanced, right? Fatty stools. Where do the enzymes that break down fat come from? Pancreas. Correct. So your pancreatic enzyme. If you don't have pancreatic enzymes, or that can be excreted in the sodium chloride channels, what might you have? Yeah, I heard it. Cystic fibrosis. Yep. So fatty stools are always associated for kids with cystic fibrosis. How are you going to diagnose that? Sweat chloride cuts. Exactly. So that would be a way to do a fourth order question. That's actually really, I should write that question. I won't for you guys. The test's already written, but would be something like that I've seen on PANTS, where they will give you a child has a growth chart that looks like that they're wasting. Then on physical exam, they tell you there's fatty stools. What's your next test that you're going to order? So it's for sweat chloride because you're thinking this is a cystic fibrosis issue. Snoring or mouth breathing, always thinking obstructive sleep apnea. Are they not growing because they are not resting and they are not able to sleep and get that regenerative time? Recurrent wheezing, are they aspirating? Is this a recurrent infection? Those infections, HIV is a great mimicker, so it can mimic anything. So always thinking about that. And then travel. So I'm not going to ask you specifically for those things, but just things that might come up in history or on exam that can be helpful for this. Where's the answer? Okay, we're just going to go to that. Labs to think about this. So your history and your physical are going to guide this. There are no standard shotgun labs that I need you to do for things. So my favorite word is consider. No lawyer can come after me for that. I considered it, but I didn't commit to it, right? Consider is my favorite word on a note. So things to think about. Do I think that this is an anemia? Do I think that their child has a neoplastic issue? I'm going to get a CBC for that. Iron always, particularly if they're at that around the 12-month-old mark, I want to know that. A UA, not just for infection, but are they spilling protein? Are they spilling blood? Are they spilling glucose for any type of renal disease? For CMP, you can catch some renal issues, you can catch some liver issues with that. Do they have an infectious disease where I need to think of TB or HIV? Have they traveled, and I think this is a stool culture, and they have a chronic giardia going on? Lead, when do we get lead level for lab? Yep, 12 months. Thyroid, because it can mimic anything and has to do with your metabolic. Celiac is the great mimicker of things for kids. We'll talk more about that. And then do I need to get a chromosomal analysis? Do I really think that this is the symmetric type of growth faltering? And then I need to do a further genetic analysis. My outpatient management, so I want to make sure that I'm counting those calories, how much and what volumes are coming in. And do I have a close follow-up plan? So this is children that I'm seeing every week or multiple times a week. That's how what I mean with frequent weight checks in clinic, so every week. Dietitian is going to be your first person, so it's not always GI unless I give you symptoms. If I give you symptoms where they're vomiting, diarrhea, regurgitation, then that's GI. If they're not having any GI symptoms, don't get into GI. Your nutritional management, they're amazing. I have a whole book of peds nutrition if you want to nerd out with me on that, of how much a child should be getting for catch-up growth, but roughly it's 1.5 times what they would need for normal growth. High caloric foods, and we wanted to say, do they need more protein, do they need more carbohydrates, or need more fats? What do children gain weight from?
Fats.
Yep, we want fats, and that's going to help that brain development. So that's why we say adding things like peanut butter, adding things like avocado, butter, any of those good fats for these kiddos. And making sure we're supplementing iron and vitamin D or other multivitamins. It's multi-treatment, multidisciplinary treatment approach in general for these kids with failure to thrive or growth faltering. So you've been following a child since birth. You have concerns with the growth chart trends. So not just one point in time, but these trends. Which of the following makes that diagnosis of failure to thrive or growth faltering? Third percentile for length. How about that? Weight in the 80th percentile, median weight for height.
No.
Child's length has increased across 1 percentile. Child is in the 3rd percentile for weight, or the weight percentiles have not changed from last visit. This is a bad question. I took it off an old test, but what's the answer here? What's your best answer? Delta, yep. So why is A wrong?
Length.
This is length, not weight, correct. Why is B wrong? 85th percentile,
That's
median
pretty good.
weight for height, what's it supposed to be less than?
Less than the third.
Less than the 80th. So that's why that one's wrong. Child's length has increased and crossed 1 percentile since last well visit.
It's making progress.
Yeah, that's good, right? We want that. But we don't want that. D is correct. E. E B could be, if they haven't changed from the last well visit, I would expect that they would gain weight, but I can't prove that that's not also right. So that's why this is not a great question. It could be dual credit, but your answer here is D. You know it's the 3rd percentile.
Put it back. Dual
We'll
credit.
cut it there and do congenital infection